Well, hello, everybody. It is wonderful to see so many people joining on to this webinar, and it is a distinct pleasure to be able to do the introduction. I'm the president-elect of the International Society of Sexual Medicine. My name is Gerald Brock, and it's a pleasure to be able to partner on this webinar with WAS and ELNA. The idea, of course, is that we want to talk about sexual pleasure today. Can I have the next slide, please? And I can't think of a more appropriate topic for us all to talk about just before the weekend begins. The ISSM, of course, has a vision, and a vision is that every human being has the right to a healthy and satisfying sexual life. We have a mission and a purpose, and our statements are listed here. Really, the idea is that we believe the ISSM hopefully will be and is the most respected and trusted source of information related to human sexuality. And we do that through education, and I'll outline some of our educational programs, professional development, and webinars like this are critical to increasing your knowledge and keeping up to date on all of the latest information. We also achieve that, of course, through our publications, meetings, in-person meetings, virtual meetings, and are lucky to be able to partner with groups like WAS to be able to make sure that happens. Next slide, please. You can see this map shows how global we are, truly an international society with affiliate organizations through 7 different affiliate organizations, and also through the ISSWISH, which is an affiliated society as of 2021. So we have representation in all of the continents in the world except Antarctica. New slide, please. This is really the crown jewel of ISSM in many ways. Certainly our in-person meetings are critical to evolving information, but the idea that we can look at research and clinical practice and can be peer-reviewed in a series of 4 different vehicles to provide that information across the world, whether it's the Journal of Sexual Medicine, really focuses on innovative new clinical trials and clinical data. Sexual Medicine, which is an open access journal and allows for wide distribution of some of that research productivity of many of our members and non-members. Sexual Medicine Reviews has a high impact, 5.3, and I think that really reflects the fact that people do look at review journals to try and understand topics of concern and get the latest information that certainly textbooks that we were all used to in the past can't provide. And then another wrinkle in the ISSM group of publications is our video prosthetic journal, which provides surgical techniques and video learning for our members. New slide, please. I'll pass it along to ELNA and WAS, and I look forward to having a really interesting and exciting webinar today. Thank you all for joining us.
Thank you very much, Gerald. I must say it's a particular honor for me to be here co-hosting this with you, Gerald, because I'm also a member of ISSM, being a medical doctor from South Africa myself. And if I just look at those journals that you showed now, I know that it would have been impossible for me to be a medical doctor in South Africa in sexual medicine if it wasn't for the journals, to be honest. We refer to those journals literally on a weekly basis in our group. We have a big group of over 50 sexual health providers, and I can only encourage people, if they're not members of ISSM yet, even if it is just to access those journals, it's absolutely worthwhile. Anyway, I'm here to talk about WAS, and in this administration, our vision is sexual health, rights, justice, and pleasure for all. And the next slide, what does WAS do? We are actively creating a world in which people have access to sexual health, rights, justice, and pleasure. And we achieve this through strategic collaborations like the ISSM, globally and regionally. You'll have to go back to that slide, sorry, Lillian. I just want to read that. Educate sexual health professionals. We promote and showcase sexuality research. We do standard setting in sexology. We do sexual health and rights policy making, and we advocate for sexual health, rights, justice, and pleasure. And then when it comes to the Sustainable Development Goals, we've got consultative status with the UN, and these Sustainable Development Goals are extremely important to WAS. And if you go to the next slide, you'll see that so many of these 17 goals are things that we work towards. And how do we do that? You can go to the next slide. We have this theory of change that is basically our dream for sexual health in the world. And that says people make informed, autonomous, ethical, and respectful sexual health choices. Laws and policies are applied to ensure that sexual health rights and justice for all. Sex positive attitudes and beliefs are embraced around the world, and diversity is widely accepted. Scientific evidence and rights-based, experience-informed, context-sensitive knowledge about sexuality is widely accessible and not censored. The next slide. Next one. Gender equality is achieved within the most comprehensive understanding of gender, including that of trans and gender diverse individuals. Sexual violence and harm are eliminated under all circumstances. Comprehensive sexuality education is standard practice in and out of school, and professional education and standards in sexology are well developed and regulated on ethical and best practice guidelines to ensure the highest quality of clinical and sexual health services around the globe. Next. We have our journal, the International Journal for Sexual Health, and in this one, the Sexual Rights Declaration was published, that you will see on the next slide. There are 16 different sexual rights, and many of them are really important for clinicians, including the right to the highest attainable standard of health with the possibility of pleasurable, satisfying, and safe sexual experiences. It is the human right of your patient to experience pleasure. And you, as a healthcare provider, can facilitate this process for them often, or you can make it more difficult for them by what you just prescribe, and we're going to look at that today. And then there are also some other rights that are all important to your patient and that you can take a look at. I can share some of this in the chat. Next slide. And now we have the Sexual Pleasure Declaration at WAS. The WAS Declaration on Sexual Pleasure highlights the importance of placing sexual pleasure in the forefront of sexual health promotion, comprehensive sexual health education, and services and sexual health policy, reinforcing the concept of pleasure as an essential ingredient of sexuality, sexual health, sexual rights as defined by the WHO. And on the next slide, you'll see the Sexual Pleasure Declaration. If you haven't read it, I encourage you that you do so. I'm of course not going to read through all of this right now, but it is a comprehensive document that sets the standard for the promotion of pleasure worldwide. And the reason why it's important is not so much about the personal pleasure that every one of our individual patients can experience, but it is more important on a political level, where we talk about gender equality as well as the health of societies. In relationships where there's more pleasure, societies are healthier because the relationships actually are, it's happier relationships that tend to be more stable. And that is what WAS does. So as you can see, there's great synergy with ISSM in the professional education of the education of professionals. And then our mandate is also a bit wider in talking about the policy making as well. And then on World Sexual Health Day, our theme was Let's Talk Pleasure. And that's exactly why ISSM asked us to join them for this webinar, in order for us to talk pleasure here tonight. And I thank you for joining us. Thank you for putting in the chat where all of you are from. It's wonderful to see people from Indonesia to America and some African colleagues here as well. So thank you for being here, and I hope you enjoyed tonight. I am going to introduce you to Alan Jahami, who is the Vice President of WAS. And he's currently Emeritus Research Professor at the National Institute of Health and Medical Research in Paris, and he is the editor of the journal Sexology, European Journal of Sexology and Sexual Health. He serves as a full member of the International Academy of Sex Research since 1994, and also as an expert in various task forces at the WHO, UNESCO, the French Supreme Court, and the French Ministry of Health. He created and developed a university diploma on sexual health and public health at Paris University, and he served as the scientific director at UNESCO, chair in sexual health and rights. He has published several books in French, English, and Portuguese, including histories of sexology between science and politics. Alain, I hand it over to you.
Thank you, Elna, for this introduction. I'm very happy to be here, and as I just wrote inside the chat in French, l'union fait la force. United, we shall be stronger. It is important to put our strengths and competencies all together to develop our field, which is ultimately sexuality and sexual well-being, through different ways, which is sexual medicine on one side, but also comprehensive sexual education, research, and activism. So I am going to present immediately the first speaker, who is Professor Erik Jansen, who is, oh, excuse me, I realize that I have forgotten to say something about the question and answer, which will come after the presentation, and you have to use a Q&A button in the chat, and then make sure that you add the name of the speaker to whom you are addressing your question and they will start just after the last presentation, which will be the Patricia Pascual presentation. So sorry for that. So I come back to Erik Jansen, who is professor at the Institute for Family and Sexuality Studies at the University of Leuven in Belgium, and particularly a senior research fellow at the Kinsey Institute in the USA. He published extensively on a lot of topics on sexual psychology, physiology, aggression, risk, sexual dysfunction, relationship, but he's mostly famous for his development with John Bancroft, the dual control model on sexual response. And for that and other work, he received a quite impressive number of scientific awards, including twice the Hugo Beigel Award and other awards. Erik Jansen is a past president of the International Academy of Sex Research, a very respected organization, and currently serves, finally, as chair of the scientific committee of the World Association for Sexual Health, the WAS. So Erik, please, you can start. This is your turn. I'm happy to listen to you.
Thank you so much, Alain, for that very nice introduction. I hope you can all hear me okay. It is, for me, it's always a pleasure to talk about sex. And I will spend the next few minutes on a discussion of some aspects related to this construct of sexual pleasure from a research perspective. Clinically, the next speaker will talk more about that dimension. But in the clinic, of course, often the problems that clinicians deal with have to do with sexual function, relationship aspects even possibly, but not as much directly focused on pleasure. One of the points I'd like to make, and that has been made more recently, and that you will come across more, I think, in the literature in the future, is the idea that pleasure is not necessarily just something that you consider an outcome, potential result of sexual activity, but also possibly a potential requirement to actually function well sexually, in terms of, for example, sexual arousal, sexual response. So this is something that we still, I believe, need to develop more also from a research perspective, because there's a lot of research on topics like sexual satisfaction, but actually less so on sexual pleasure. Can I have the next slide, please? So the WAS as well as some other organizations, the World Association for Sexual Health, as well as other organizations, increasingly focus on the importance of sexual pleasure. And this is from the declaration that Alma mentioned before, in recognition that sexual pleasure is a fundamental part of sexual rights, sexual health, and sexual well-being. We, as an organization, affirm that sexual pleasure, and this is a definition, is the physical and of psychological satisfaction and enjoyment derived from shared or solitary erotic experiences. So the second part that you see here on the slide, self-determination, consent, safety, privacy, confidence, and the ability to communicate and negotiate sexual relations are key enabling factors for pleasure to contribute to sexual health and well-being. Sexual pleasure should be exercised within the context of sexual rights. I will return to this second component in a little bit in terms of the relevance also of that notion of sexual pleasure in the context of consent and actually having a partner who also is enjoying the sexual activity as an interactive process almost. So next slide, please. Sexual pleasure is the physical and of psychological satisfaction and enjoyment derived from shared or solitary erotic experiences, including thoughts, fantasies, dreams, emotions, and feelings. So we can already, again, I'm talking from a research perspective, what exactly is sexual pleasure? I will later go into a little bit more into the distinction between sexual pleasure at the intrapersonal and the interpersonal level. But here in this slide, you see that we also talk about satisfaction. Now, there is quite an extensive literature on sexual satisfaction, what it is, the determinants of it, and less so of sexual pleasure. Next slide. Thank you. So sexual pleasure, apparently, at least this is how we approach this, it involves satisfaction and enjoyment. Next slide, please. And you see this reflected in the literature on sexual satisfaction. This is a quote from a paper by one of our colleagues, Patricia Pascoal and others, where they say mutual pleasure is a crucial component of sexual satisfaction. So this is one way to think about pleasure. Is it a way of looking at sexual satisfaction? Is it part of sexual satisfaction? Is it something that feeds into it, etc.? Next slide, please. And a similar paper on sexual satisfaction, Stulover and colleagues talk about pleasure as a dimension of sexual satisfaction. So what's important, I think, about this is various things. Is satisfaction partly determined by pleasure? Yes, I think generally the consensus is yes, it is possible. It's a component of it, but that means that you can that there are other determinants, and that probably you can report being sexually satisfied even though you do not experience a lot of sexual pleasure. If your definition of sexual satisfaction is more determined by relationship aspects and whether or not you just engage in sex and you're able to have experience sexual responses, then you may be satisfied, but that does not necessarily mean that you experience sexual pleasure. At the same time, the other way around, you may experience sexual pleasure, but to what degree does that mean you're sexually satisfied? So this, again, from a research perspective, is something that we need to do more on, because those are, I think, important questions. This is from another publication by Mitchell and others who recently sort of tried to define different pillars, as they say, of comprehensive public health in relation to sexuality. And they talk about sexual health, sexual justice, sexual well-being, and sexual pleasure as different components of sexuality, that overlap to some degree, but not completely. The next slide, please. So I want to say a bit more also about, okay, when we're talking about sexual pleasure, what is it? And obviously, most research, I mean, probably a lot of people think about, well, sex is hopefully, when everything is going the way you would like, to very satisfying, but also fun and pleasant. So, and it's at an intrapersonal level, of course, there's research on, next slide, please, on the, and next slide, it being something that you can experience. Sex is connected to reward functions in our brain, especially experiences like orgasm. So at the intrapersonal level, sexual pleasure is something you feel, something you experience. But there's still also, again, from a research perspective, a lot that we still, I think, need to explore. We may think sexual desire is a positive experience. That is kind of how we tend to approach it and think about it. Yet, you may experience sexual desire in combination with mixed affect, negative affect. You may experience desire for people or in certain situations that are not appropriate. So it may actually be quite a conflicted or ambivalent even experience. So sexual desire is in itself already complex and not necessarily something that's just positive. The same applies to sexual arousal. Being in a state of sexual arousal, we could consider a pleasant state, but it is not necessarily always like that. So how does sexual pleasure really relate to that? And it's sexual pleasure potentially, can we go back, please? How is it related to potentially feelings of sexual arousal, maybe more so than of physiological reactions? To what degree is it related to desire? At the interpersonal level, we know it may sometimes, at least when you put people in a brain scanner, that is the conclusion of some studies, be something similar to what happens when you eat chocolate. But even chocolate can sometimes be associated with guilty or mixed feelings. So how does sexual pleasure fit in? Sexual pleasure, probably by definition, is really a positive experience. So this is one of the maybe cleanest terms we have to focus on the positive aspects of being sexually aroused or sexually engaged in situations, which often, not always, but can be combined with mixed affect, mixed feelings, etc. So that's at the interpersonal level. What are the determinants of those experiences? When do you exactly experience sexual pleasure? Even with orgasm, which is considered by many the ultimate form of experiencing sexual pleasure. Even there, in some cases, that may not always be as intensive or as pleasant, but obviously, if the conditions are right, it is something that is inherently positive. Next slide, please. And we probably do have a lifelong capacity for physical sexual pleasure. We know from studies, a lot of research, that children can experience very positive feelings, touching themselves in certain areas. And so that is probably a built-in physiological propensity or mechanism that is there. But obviously, a lot of conditioning, learning processes may impact how we, what sort of situations we consider appropriate for those experiences and behaviors, and also may actually already at an early age impact how we feel about certain things. But in principle, that capacity is there, and there's no reason to assume that the capacity for sexual pleasure really would change in a negative way with increasing age. Okay, at the interpersonal level, next slide, please. Sexual pleasure, you can look at it also from that perspective. As in the WAS statement, sexual pleasure statement, it's referred to, but this is another way to describe it: self-determination, consent, safety, privacy, confidence, and the ability to communicate and negotiate sexual relations are all key factors in understanding sexual pleasure in contexts where there's a partner involved. And of course, there are a lot of different settings and situations. Could you go back, please? Thank you. In which sexual pleasure and sexuality can be expressed, but in many conditions, many situations, I mean, it is a dyadic experience, something interactive, something with someone else. And so you can look at sexual pleasure from this intra-individual experience related to positive feelings and pleasure derived from bodily sensations, but there's also obviously an interactive and interpersonal dimension to the experience of sexual pleasure. And it is an important topic, I think, from that perspective as well. Sexual pleasure, if you look at that from a dyadic or relational perspective, is something you really can only experience if the other does experience, if the other experiences it as well. And so there is no sexual pleasure. You may experience it on your own in situations when there is no consent as a perpetrator of sexual aggression, for example. But obviously, a consent is required for the experience of sexual pleasure. So sexual pleasure as a way of looking at sexuality and sexual interactions goes beyond the experience of orgasm, etc. It is in interpersonal context as well, a condition for sexual response, for a positive sexual experience. So again, it's not just something that we should approach as a potential outcome. It's much more part of the whole interaction of the whole process of becoming aroused, of experiencing orgasms, and of being able to function well sexually. Next slide, please. So I want to end with some thoughts that I highly recommend this paper. Not because I'm a co-author on it, but because I really think it is an excellent paper written with my colleagues, but mostly by my dear friend and colleague who passed away earlier this year, Alan Lam, which discusses one very large topic in this respect, and that is differences between a man and women in sexual pleasure. Next slide, please. And the case that is made in this article is that there are substantial gender differences in the experience overall. When you look at the literature as a whole in the experience of sexual pleasure, especially when it comes to, for example, the frequency of experiencing orgasm in sex with a partner, as well as the role, the presence of, for example, pain, which is much too common and is very gendered in itself. Women experience quite often pain, and which points at potentially all kinds of mechanisms, but one important one may be just the lack of sexual arousal to begin with. And again, this points at the relevance of having sexual pleasure, not just as an outcome, but also as a condition for good sex, for positive sexual experiences. The point that's made in this paper is that those gender differences exist, but there are many similarities in terms of the capacity to experience sexual pleasure. And we need to focus more on those as well. So I think, next slide, please. I will end with saying that I think from a research perspective, we really, this is an exciting new opportunity because, again, more research has been done on sexual satisfaction, of which sexual pleasure might be a component. But sexual pleasure in itself, I think, deserves more focus clinically as well as from a research perspective. And research could contribute to our understanding of the nature of it, the intra and interpersonal processes that are part of that and that facilitate, prevent, or reduce pleasure, and the relevance of sexual pleasure, obviously, to sexual well-being and health. Next slide, please. Thank you.
Thank you, Eric. That was a wonderful presentation, which raised, of course, a series of questions that we may discuss or not tonight. It's my pleasure, my great pleasure and honor now to present Dr. Elna Rudolph, who you know already, who is the current president of the World Association for Sexual Health. She's a medical doctor, and she has an exclusive career in sexual medicine in South Africa for more than a decade. She qualified in South Africa and did most of her postgraduate in Sydney in Australia. She has been a member of the ISSM for many years. She enjoys her role in WAS, where the multidisciplinary approach to sexual health is performed through a professional education, research, and advocacy to ensure sexual health and right for all. Elna is also a friend instead of being the president of WAS, and I'm sure we shall remain friends with all what we do together. Please, Elna.
Thank you very much, Alan. Yes, something special between Alan and I is that we share a birthday. We are exactly 30 years apart, so that's always special to me. Okay, so how to ethically bring pleasure into the sexual medicine consultation. We are very worried about clinicians just being interested in porn and wanting to talk kinky to patients, and that might be actually dangerous and unethical within the clinical setting. But of course, as you know now from WAS, we are absolutely promoting pleasure, and we know that you as clinicians are in the very best position to promote pleasure to your patients. But how do you do it ethically? So you can put up my first slide, please. As you know, we talk pleasure at WAS this year on 4th of September, World Sexual Health Day, and we had fantastic engagement. And this is one of those engagements where we are so happy to teach clinicians about talking pleasure to patients. Next. And this is my location of South. I'm a cisgender, heterosexual, vanilla, monogamous, white African, privileged Christian, ethical, science-based and experience-informed medical doctor, and I volunteer as the president of WAS, and of course I'm a mom. So why on earth would I, that come from the country with the biggest Gini coefficient in the world, where poverty and HIV and a lack of electricity, by the way, that's why it's so romantic here where I am. We don't have electricity because we have load shedding. There isn't enough electricity for everybody in the country, so we take turns with electricity. Why would I be here talking about something as frivolous as pleasure? Next slide. International comparative research consistently show that diverse forms of sexual pleasure improve both individual happiness and overall health, as well as relationship quality, which can contribute to the health and well-being of individuals, couples, families, and communities. You see that little family that I show you there? Talking pleasure makes the world a better place for them and for other people like us, as well as any other person on the planet. Meta-analysis consistently find evidence that pleasure-inclusive interventions reduce sexual risk-taking and improve sexual health. Sexual pleasure has also been linked to improved cardiovascular health, perinatal health, overall health, and mental health. Taken together, the studies cited that solo and or partnered sexual activity is associated with improved health, longevity, immunity, pain management, self-esteem, and a reduction in stress. Sexual pleasure also helps to cement the kinship structure of couple relationships and contributes to overall happiness in people's lives, whether they are in partnerships or not, and is associated with aspects of overall health. Next. So, to the extent that the society is concerned with the well-being of individuals and the stability of couples, families, and communities, it is in the interest of policymakers to recognize that the importance of sexual pleasure and to implement sexual health promotion programs that address sexual pleasure as fundamental to individual and partner health and well-being. So this is from the technical document that came at the back of the Sexual Rights Declaration, which I'll also share a link to with you. And this is basically the essence of what we do, but really very few people are better positioned to promote pleasure than clinicians. You actually carry a license to talk to people about pleasure, and many people are desperate to increase their pleasure. And if they do, there are great advantages, as you have seen. But how do we do it ethically? Let's take a look. Next slide. So this is the declaration again. You can go to the next one. I've shared it in the chat. You can go and find the link there. And this is a quote from the article that Eric referred to that I have also shared in the chat with you. And it says that sex is a sexually pleasurable activity affectionately shared among equals. Isn't it the most beautiful quote? Sex isn't, if you look at sex from an epidemiological perspective, if you're worried about HIV and STIs and unplanned pregnancies, then you tend to think about penises in vaginas. But for us who work with sex on a daily basis, we know that sex is a sexually pleasurable activity shared affectionately amongst equals. And if any of those words aren't there, if it isn't equals, and if it isn't affectionate, and if we will talk a little bit more about how you know whether the person is safe in that relationship. If it isn't there, we're worried. But sex, if your narrative of sex, or your notion of sex is that it is this very tight range of activities, and if your idea of what can bring you pleasure is rigid, then it's not helpful. Nobody should be in a position where their idea of what brings sexual pleasure is rigid. And if you as a clinician think sex is when a rigid penis goes into a vagina and you don't see other possibilities for your patients, then your patients will lose out, and you personally will also lose out. So let's take a look at what we can do about that. Next slide. How do you ethically bring the pleasure into the sexual medicine consultation? Like in all other sexual health consultations, you use the PLICIT model. It's very simple. On the next slide, you'll see that it stands for permission, limited information, specific suggestions, and then intensive therapy. And you might need to refer for that if you are not trained as a psychotherapist. So next slide. The first step is, how do you know that you have permission to talk about sexual pleasure during the consultation, and how do you give the patient the permission to talk about it? If you look at those old sexual health questionnaires, the way that probably most of us were taught, you ask, how many partners did you have? Did you have partners outside of the country? Are you having anal sex? You're asking these very intrusive questions, which isn't natural. The average gynecologist, urologist, is not going to ask those questions of patients. And also, just starting to talk to people about what gives them pleasure is actually really quite uncomfortable and might not be appropriate at all. So how do you venture into that space? Let's see. Firstly, on the next slide, you need to make sure that you have the permission to talk about sexual health and ultimately sexual pleasure. You have to practice ethically. So on the next slide, you'll see that the WAS has these ethical principles. And the first one says that sexologists, and that's people working in sexual health. The definition of a sexologist is contentious, and we are reworking it at WAS at the moment. But if you're working in sexual health, you shall have appropriate professional preparation and maintain ongoing commitment to continuing education, which is exactly what you're doing here tonight. You must operate only within the area of your professional expertise and competencies. If you talk pleasure because you're a urologist and now you find out that this person can't experience pleasure due to trauma, please refer. Do not think that because you can do a certain part of sexual medicine, you're working on your own. You know that you can have a PhD in sexual health and you still need to refer for what you cannot do. And if you are a psychologist and the person is struggling to experience pleasure, it might be due to a hormonal problem or them being on the wrong medication or suffering from a disease. Please refer. Stick to what your scope is. And inform your clients of exactly what your qualifications are. So on the next slide, here are some ways that you can get this appropriate professional preparation. Most of the people on here tonight are healthcare providers. You are already a sexual health provider. As a healthcare provider, people expect you to provide them with sexual health services. You might just not be a very well-informed or very credible one yet, but that's why you're here. So the pleasure principles is a great way to start. This is a link that I'll also share after my talk, where there's a whole training toolkit. If you haven't done this yourself before, please go and do it. Do it in your clinics. Teach the people around you to be more positive, to put rights first, to think universally, to be flexible, to talk sexy, to embrace learning, and love yourself first. First, see those possibilities in your own sexual experience. Of course, when we talk to patients, it has nothing to do with our own sexual experiences. But if we are rigid about our ideas regarding pleasure, we will portray that onto our patients. Next slide. Then there is the training toolkit of the Global Advisory Board. And this is a fascinating toolkit that you can also use to train your local clinic. But there's a particular tool in here, the pleasure meter, on the next slide, that I want to show to you. And on the pleasure meter, some of these things that Eric referred to, like consent, and the next slide, please. Let me just get my self-determination and safety and privacy and confidence in that. You can actually use this toolkit to rate. This is like a barometer of your patient's potential for experiencing pleasure. Pleasure is not only about orgasms, as Eric has said. There needs to be pleasure. Pleasure is almost a barometer itself of sexual health and well-being. So all of these things need to be there in order for a person to experience pleasure. But I'll show you how you can use it in clinical practice. Next slide. Then it's extremely important that you do a sexual attitude reassessment. And this is one that we're hosting by Sasha in South Africa, for instance, at the moment. There are more online ones coming up now. And you cannot portray your own values onto patients. Now, if you're just there to sort out their erectile dysfunction, there's not a lot of value discussing happening. But if you start to talk about pleasure, it can be quite difficult for you not to yuck another person's yum, for instance, and to not portray your values onto them. So it's very important that if you want to take this up and be that kind of clinician that can also venture into pleasure with your patients, please do a sexual attitude reassessment. Okay, next slide. Then you have to practice ethical curiosity. You do not just ask patients questions about their pleasure. And this is the whole long process that is based on the ISSWITCH process of care, actually, for hyperactive sexual desire disorder. I just used the way that they ask the questions there and reworked it a little bit for you tonight to incorporate pleasure. So if we can go to the next slide, you will start with, if you don't mind me asking, are you sexually active? And that is the next slide. I wouldn't just say, are you sexually active? You will see on the previous slide, I said, well, if you don't mind me asking, are you sexually active? Certain patients, you've already talked about sex a lot, so obviously they don't mind you asking. Another person that comes into your office for a pap smear, this is what you will ask them, or for erectile dysfunction consultation, or whatever the case might be, transgender patient, for instance. If they say no, you say, is it by choice? Next. If they say no, it is not by choice, then you say, would you like to discuss that with me? Next. And if they say no, they don't want to discuss it with you, do not close the book and do not feel stupid about it, but say, I want you to know that you can feel free to discuss it with me whenever you're ready, and that you have a sexologist on your team that you can refer them to. So always give them the option to go and talk about sexual health and pleasure somewhere else if they don't want to talk to you. Next slide. If they say that they do want to discuss it with you, you just say, how can I help? That's it. The patient then brings forward what's necessary. And from there, you can ask deeper and deeper sexual health questions. But how can I help is a great place to start. Next, if they say they are sexually active, then So which is what most of your patients will say, of course, yes, I'm sexually active. Then you say this, are you experiencing any challenges regarding your sexual function or sexual pleasure? Remember that, because up to now, we as clinicians weren't trained to ask that particularly. So experiencing any challenges in terms of your sexual function or sexual pleasure that you would like to discuss with me. Next, then the option is maybe yes, how can I help? Or next, the option is no. Then you answer with them in the same way, saying that they can bring it up at any point, or you can refer them to a sexologist, or you might have a nice website or the ISSM's website or some other resource that you can refer them to that they can go and check things out. So next slide. That is a very simple process that you can follow to ask every single patient that you see in your practice about pleasure. Are you sexually active? Is it by choice or not? Do you want to discuss it with me? Yes. How can I help? No. Okay. You're welcome to do so in future. That's it. Then you're practicing ethical curiosity. Then the patient has given you the permission to now ask them more questions. You have to then at some point ask them about these enabling factors that Eric referred to from the sexual pleasure declaration. And those are, on the next slide, self-determination, consent, safety, privacy, confidence, the ability to communicate, and the ability to negotiate. We as clinicians are so used to the FSFI, you know, every single person that sees me for a sexual medicine consultation, a female, would complete the FSFI, you know, so we talk about the outcome of pleasure, what we think is the outcome of pleasure in the form of how easily can you reach your orgasm. But how often do we as doctors talk to patients about self-determination and their ability to negotiate consent and whether they have privacy and safety and all of that? But that's actually the enabling factors for pleasure. So you do want to, rather than asking about the amount of partners, start asking about these things. Next. That's that scorecard that I showed you that you can use for this. And then limited information on the next slide. I think it should actually be legitimate information and not limited information, because we don't want to give patients limited information. We want to give them all the information they need. So make sure that you use available tools to enhance your own skills, which I referred to earlier, to be more sexual pleasure focused provider in your practice. And then on the next slide, you can then also respond to your patient's concerns with scientific evidence and rights-based experience-informed information about sexual functioning and sexual pleasure. On the next slide, you will see there's online courses, websites, pamphlets, support groups. Next slide. And for instance, in our group, we have these self-help courses that is very culturally appropriate in our environment, that our patients already trust us, so they can easily go to something like that. You can develop something similar for your patients to increase pleasure or refer them to already existing programs. Next. And then you can affirm the possible impact of medication and medical conditions on pleasure. So if you are giving a patient an anti-androgenic contraceptive pill, for instance, you can just tell them that there is a possibility of this affecting their pleasure. You don't have to say it will, because we know from the research that it will not necessarily, but you can affirm whenever you prescribe something that could potentially impact their pleasure, the antipsychotic, the psychiatric medicine, the antidepressant, just affirm that for your patient. Next. And then you can give your patients the vocabulary to enhance the communication about sexual pleasure. Next slide. And this vocabulary is not very difficult. My 3-year-old knows this vocabulary. For a person to communicate with their partner how to give them better pleasure, they only need these words: harder, softer, faster, slower, up, down, left, right, deeper, and stop. That's it. You do not have to be able to say clitoris out loud to be able to communicate to your partner how to give you better pleasure, but you need to be able to negotiate consent and negotiate with that partner and agree with them that you're going to go into a session where you're going to guide them to give you better pleasure. And not all patients have the ability to do that. Check. If you talk to patients, they're often not in the kind of relationship where they can do this. Next. And then when it comes to specific suggestions, next, you will manage the chronic conditions optimally, but with drugs with minimal sexual side effects. This is now where you as an expert come in and say, in your condition, for your blood pressure, I'm going to take you off the beta blocker and put you on the ARB or onto another antidepressant or whatever the case might be. Next. Where appropriate, you will offer medication that can address sexual dysfunction and enhance sexual pleasure. Your patient has the right to enjoy the benefits of scientific progress. So we now have multiple drugs that have been registered that could potentially affect this, and some are unregistered but researched that could affect a patient's pleasure. And it's your patient's right to access this medication. Have the discussion with them whether they want to use it and whether it's on label or off label or what the risks involved are, but your patient has the right to it. Next. Then Sensate Focus remains a very valuable tool. I have a 15-minute video on YouTube where I explain to my patients how to use, how to do it. It's like the doctor's DIY version. The psychologist will flip, because I know they see patients 10 times sometimes before they even start talking about Sensate Focus. But this is a very easy doctor's DIY version of Sensate Focus that just brings out the problems. When you follow that patient up, then they basically tell you we cannot communicate, and that then gives you the reason to refer them for the couples therapy or whatever is necessary. So you can try that. Next. And then intensive therapy. On that last slide, I just showed that you might need to refer for intensive therapy. For if there's a history of sexual abuse and you are not a psychosexual therapist, please refer to a person that's specialized in this field. It's a very specialized field. And patients who have low scores on any of that pleasure meter that I showed you, that you don't feel that you have the ability to help them to gain more agency, to increase their scores, refer that. Any patient that you don't feel comfortable, you might need to refer, or a patient that asks for a referral. So as you can see, basically 99% of the consultation and the whole process of increasing pleasure is possible for any person, any healthcare provider, and that there are ways of increasing your knowledge to make you a more credible and competent sexual health provider in order to better help your patients reach their potential for pleasure. I won't read this last slide for the sake of time, so thank you very much.
Thank you, Elna, for this fascinating lecture in which I have learned a lot, and thank you. So now I'm going to present Patricia Pascual from Portugal, from Lisbon, who unfortunately is not with us tonight due to family problems. Patricia is an ex-member of the of the advisory board of the World Association for Sexual Health, so she's a friend. She's a psychotherapist and psychotherapy supervisor. She's assistant professor at the Lusofona University in Lisbon. She's currently the president of the Portuguese Society in Clinical Sexology, professor at the university, coordinator of the Masters of Clinical and Health Psychology, deputy editor-in-chief in the Sexual Medicine Journal, and vice chair of the education committee of the ISSM. I'm always wondering how these people, these women, can do all that they do and sleep sometimes. So we listen to you, even if you are not here, Patricia.
Hello, my name is Patricia Pascual, and I'm very honored to be here. And before I start, I just want to disclaim that I'm a cognitive behavioral trained therapist, and this may frame, and definitely does, what I present here today as a reflection on the challenges in clinical practice for those who want to address sexual pleasure. And firstly, I would like to highlight that there is an explosion, of course, in the literature and the advocacy about sexual pleasure, but is there a consistent work that helps and guides clinicians in their evidence-based practice? Not really. So this means that clinicians have to face a lot of challenges. One of them, of course, the first is that there is not a comprehensive model that integrates clinical findings and that addresses pleasure in clinical context. So when we are practicing and that we want to address sexual pleasure, we don't have a lot of theory to rely on and to develop our work. And of course, not so much empirically validated knowledge either. So what we should rely on is in our theoretical model and integrate the knowledge we can acquire from different sources that is reliable. Of course, this is a middle range kind of position, but it's still the best we can do, I think. Another thing is when we are trying to look for evidence, we have to be very aware that there are several literature biases. For example, the overlap with orgasm and the overlap with satisfaction. These are, of course, two concepts that are highly related to sexual pleasure, but they are not synonyms. So they don't mean the same. Orgasm is an important correlate, and it's probably a strong predictor of sexual pleasure. But it doesn't encompass everything that is involved in such a multidimensional concept as sexual pleasure. And satisfaction is not necessarily related to sexual activity. One may be satisfied with their sexual life without meaning they have a sexual active life. So these are distinct concepts. However, in literature, sometimes in the titles or even in the session, the researchers, they go and get literature from orgasm or satisfaction or even measures of orgasm frequency or intensity or satisfaction to discuss pleasure. While this is not a huge problem because we can, of course, frame, it obscures the lack of studies that actually address sexual pleasure as a construct in itself. Another problem, of course, is sampling, as most studies are developed with community samples and with non-clinical samples, with people with illiteracy. We all know the shortcomings, and this means a lot of important groups are being neglected. Here, for the purposes of my talk, I would say people who have clinical diagnoses or have sexual problems without even diagnosis, they are subclinical. They're quite absent from the literature, and this creates a strong bias also, and it makes our work more difficult as clinicians. And what doesn't help is the manual vagueness. We don't have to work with diagnostic manuals such as ISSM-5, which I bring here today, but these are important. They are important grounds for research and sometimes to make a diagnosis and frame the way we intervene. And what we find is a very promising approach for example, DSM-5 to sexual pleasure, and DSM-5 puts sexual pleasure at the core of the diagnosis when they say not to experience sexual pleasure is important for the diagnosis of sexual problems, okay? And they actually even acknowledge that sexual pleasure is determined by culture, or is at least influenced by culture, but to be more precise. However, when we are looking into the criteria and there's, an overlook. Because we can find a reference to pleasure in the sexual arousal interest disorder, I think in some of ejaculation problems too, but it's not developed, it's not addressed, and it's not operationalized. So it's quite difficult for us to understand if we can really consider it clinically relevant that the person does experience pleasure, if then the criteria doesn't address it. Of course, we can think independently, autonomously, and critically. And yeah, we know that sexual pleasure is strongly associated with distress and the experience of discomfort with sexuality. So but we don't have the research that derives from the manuals to better understand it. That's my point here. So we might need some more precise advocacy and definition in this point. And yeah, as I was saying, this is a very interesting large survey developed recently. That's why I brought it from this year, that really puts sexual pleasure and problems, you know, at the same kind of level as important constructs to understand clinically what is happening. And it's really stating that sexual pleasure was significantly associated with absence of sexual problems, with orgasm frequency and engagement in oral sex in the total women sampled. And I'm bringing this information about women because the experience of pleasure by women is more or less common than for men. And this creates, of course, a lot of important questions about the gendered nature of sexual pleasure, and makes us think what we can learn to help these women and also these men, of course, and women's partners. So it's very, very interesting that we have a finding here that talks about engagement in oral sex. And I think we have to be careful because we find these, and this is important to make us think of important skills that people can develop in order to improve and maximize their sexual experience, but we should not look at it at the prescription level. So it's not like, oh, you have to do more oral sex. There's more involved in the experience of pleasure and the experience of sexuality, personal constraints, difficulties that people have to access their body and the constant context of their relationship discussed, and a lot of issues that have to be raised before we actually just prescribe oral sex. I just, have to read the literature attentively. Nevertheless, what my thought was when I read this important piece was why don't we have then clinical studies that address or include pleasure? It's very uncommon that we have clinical studies or intervention studies directed at sexual problems, and that these include pleasure or satisfaction or even distress. I found this one, and I would just like to highlight it because I think it's very innovative. It's very specific, but the approach that the research team took was to target pleasure to enhance sexual functioning. Of course, it's very specific. It's with subfertile couples, but I think it's interesting because recently more findings on this project were published, and we can see that there are some improvements in some domains when we actually address and target sexual pleasure. And you have to read the paper to see the grounds and theoretical grounds and how the authors framed their intervention towards sexual pleasure, and see how they were informed by previous research and models that do not necessarily address pleasure but might be beneficial for pleasure. Okay, and so what can we do? What challenges do we have, and what can we do? Okay, we have some measures. We have the so-called Amsterdam sexual pleasure. I think it's not scale, it's actually index that is in press. And we know already something about this measure if we read the literature. We have this really short sexual pleasure. We can use it in our practice, even as a method to introduce the topic, not so much about its value as and the normative data we have, but it's a good icebreaker when you can bring a measure to the session. We don't have a clinical interview, so there's a lot of decision making we have to do, like what we assess, what is the capacity to experience pleasure? Eric talked about it. How do we operationalize it? What are the opportunities? Because the opportunities our patients bring to us, they are filtered by their own reading and their own rationale about their problems. And shall we address sexual pleasure, or shall we stick to the client's meanings? And by client's meanings, and I'm sorry about the typos there, that by client's meanings, thinking about clients or patients that say, well, but my problem is my function is not my experience of pleasure. Okay, so what do? Do we try to impose our own view and our knowledge? Do we refrain? Do we develop more the concepts and the way this reasoning was developed? I think we have to be very aware of how much we push of our own advocacy into our patients and our own beliefs. Also, we have to think about it when we place sexual pleasure within the protocol and the therapy, because we need to see, is it the focus of the patient or is it my focus? And what do I do address it? For instance, if we are assessing the capacities and the opportunities of patient or people in a specific configuration or relationship situation, and we realize that there's a lot of inhibition and emotional dysregulation or difficulties in regulating emotion, what do I address? Do I make a referral to a psychotherapist? If I'm a trained psychotherapist, do I, because I have a case formulation in my head, I say, okay, I think there's a lot we need to work on, some psychological dimensions before we address your sexual life. And now it's very important to establish a case formulation and discuss it collaboratively with the patient, and to see if you're not really imposing your meanings, making a bad reading of the experience. And it's also good if we try to have as much knowledge as possible to explain the established correlates of sexual pleasure in clinical practice. And this leads me to another question, that shall one digitalize intervention? This means that if a patient has a complaint and it brings a lot of worries and concerns and problems with the genitals and the function, shall we degenitalize it completely, or we acknowledge that genitals are in fact part of a broader concept of a bodily experience, or a bodily or a spiritual experience that is bodily mediated towards sexual pleasure? I think these are important challenges, because if we genitalize intervention and try to give a broader comprehension of what a sexual experience is and how we can achieve pleasure in so many ways, and with attention focus and with discovering new sensations and being aware, being in non-abusive relationships, we might neglect some important aspects as difficult with genital image or disgust with genitals, for example. And also, we have to think if we have established specific interventions to address pleasure, or if sexual pleasure is actually just a side effect, a good side effect of a promising intervention that we need to keep track of, or we are, or the other way around, we are being successful in restoring function or relationship. These are just examples, but we are not actually promoting sexual pleasure, or we are not diminishing sexual distress. So these are things we need to keep track of. And okay, I just want to wrap it up. And I think we need to think of the place of sexual pleasure in therapy. We have to think of the theoretical input we bring. We have to think and consider the gender nature of the concept. And with these, I mean, also do not neglect that gender nature of the concept involves all genders and expression of genders, and do not make it a cis women issue, because there are different people that might have difficulties dealing with pleasure related to their gender identity, or the pressure to perform in a certain way because they are read as being macho or male or whatever. And we have to be very attentive of our own beliefs, that sometimes our advocacy and the advocacy we are trying to make in our lives as researchers or as teachers or as citizens and the person I have in front of me. And it's so important to have a culturally respectful practice and to listen to the person and the person's meanings and, about this person. So take home messages. Research is the basis, so try to keep it evidence-based practice. Be self-aware, work with meanings, and that this means our own meanings. Consider the contextual nature of pleasure and consider it across time, of course. And throughout the process, assess pleasure when intervening in function and distress. So some examples of landmarks in the field. This is a very good book that places a great emphasis on the cultural meanings attached to pleasure in different parts of the world and to sexuality. Some of the chapters are not focusing on pleasure at all, but they are focusing on sexual problems, and I'm talking about clinical issues. And landmark piece by Ellen Lam and her team, Eric is here, thank you for this, Eric, is, I see it as a starting point for something that is obviously blooming, and which is a work towards a comprehensive model that may help not only researchers, populations, but also clinicians. And this is it. And if you have questions, don't hesitate and contact me at my department. This is my personal, not personal, my professional email. Yeah, and I'm all yours if you want to talk about, or you have doubts, or you didn't understand part of what I said because of this bad accent. Thank you all.
Thank you, Patricia. Even if you are not here, I say thank you. And I thank you for your very, I would say, provocative at some point intervention when you focus, your attention about meaning, because we run, pleasure is a political idea, and we run the risk of imposing a very particular idea of pleasure to any patient. So it's important to remind the subjective individual dimension of pleasure. And it raised, it came to my mind, but what about pleasure in pain? The relationship between pleasure and pain. And we have physical pain and mental suffering, which are different dimensions, which may be, in some cases, related to pleasure to some people. And what shall we do, with that? So thank you, Patricia. Now we have a couple of questions in the question and response section, but also some other questions in the chat section. So I will ask people to ask their question in the section of question and response. So we have one technical and precise question, but to which Elna has already almost replied, which someone wanted to know if the sensate focus is evidence-based. So maybe Elna, you could respond to it, and also maybe Eric, who is a big scientist.
Well, I just saw that there is this article published in JSM that I am sharing in the chat at the moment. Is that now correct? I hope that yes, I'm sharing it in the chat as we speak now. The type article published in May 2022 in JSM on sensate focus. So, there are lots of different modalities these days, but for me, sensate focus remains something that is actually feasible for medical doctors to do. I think people who are trained in psychotherapy might develop different modalities, but where I find it very useful is it is a technique that increases pleasure that I can explain to my patients. Very, very simple in its most simple form, where you just explain to people, to touch each other in different ways, basically, and take turns to do so and give positive feedback. And then with the patient's permission, of course, some would decide not to do it, but when they come back, they bring back the real stuff in that relationship. So then you can make a referral, because I think many clinicians out there know how difficult it is. The kind of patient that consults you with sexual health issues, the doctor, wants the doctor to fix it with a pill. If you tell them in the first consultation that you think that their issues are primarily psychological, you're going to refer them for therapy. The reality in South Africa is they have paid me so much money that it is almost as if they want a guarantee to get a solution. If you just put it into perspective, you know, of course, in South Africa, there are many wealthy people that can afford private medicine, but then to tell them that they now have to pay that much money again and see a therapist, and that they will probably need to do that 5 or 10 times before they will come to a solution. Patients just don't do that. So I use Sensate Focus as a way to build trust with them. And yes, then their sexual dysfunction gets resolved. They increase their pleasure, it goes better, and that's the end of it. And for some, it brings up the real issues, which I then refer to a therapist, which I'm not. But the evidence, I guess, you'll find in that article.
Yeah.
But Eric, please, I would love to hear what you have to say about it, Eric.
Yeah, Eric.
I think it's a fascinating question. You can ask similar things about other therapeutic approaches, of course. Many evaluations of treatments that are available are very narrow in their evaluation. Now, does Viagra lead to erections? Is not the same question as does it improve your sex life and does it make you happy? There are not many studies, but there is still some recent. There have been some recent studies, or still on Sensate Focus. I think, for me, it is embedded in a larger literature. The more recent studies on mindfulness and the effectiveness of that, because this is all about the role of attention. It is about where are you with your attention, and to what degree are you focused on your sexual performance, and do you have concerns and worries about that versus you're in the moment, you're focusing on those sensations that are pleasurable. And I think there's a pretty good, strong literature, even going back to work by people like David Barlow and others that show how important attention is, and for it to be in the right place. So that would be one way to think about it. The methodology of a number of different types of evaluations of treatments is in some cases questionable, or something that we could debate, and also in terms of the focus on what exactly are the outcome measures that we're so interested in. From my perspective, I would think that Sensate Focus is actually one of the stronger things we have to offer in terms of empirical support.
Thank you, Eric. We have another question, which is more like, I would say, like a provocation. Someone is saying that, what do you think about the fact that oncologists do not care about sexuality issue after treatment? So we know at the moment that there is some evidence and there is some starting, interest since, about more than 10 years ago, there was a creation of the International Society for Cancer and Sexuality, and Hoot, our friend Hoot Janoten, was one of the founder, and I was myself participating at the founding conference in Rotterdam. And so there is an interest, but why some people still think that there is no interest among cancer? Are there any complaints from patients that they are not heard about their sexual request? Or what is your opinion, Elna, about this?
In South Africa, there are some oncologists that refer patients to our group on a weekly basis. And then, of course, there are many of whom I've never seen a patient, so I don't think that oncologists have the capacity to be doing an hour consultation with the patient. But I saw research when I was doing my master's degree, yonkers ago, about, at that time, it was on prostate cancer. And patients were offered the opportunity to see a sexologist prior to their cancer. And if I remember correctly now, it was only 12% of people who opted to see a sexologist prior to their cancer treatment, their surgery. So they were given the opportunity and they didn't take it. But then afterwards, as they develop the sexual dysfunction, they know that there is the possibility of seeing a sexologist. So even if we cannot educate oncologists or any other specialty, all the way to being able to do a thorough sexual health consultation, if we can just sensitize them and put teams around them that do specialize in this, and they can refer the patients and make the patients aware that they can go somewhere for help, or like what we're doing in South Africa, we try to inform the public that there is help, so if the oncologist doesn't inform them, they can come straight to us. But the answer is multidisciplinary teamwork. The oncologist isn't the specialist in sexuality, but someone else, a sexual health nurse, a GP might be better positioned to help. And of course, if there are oncologists who's interested, we can turn any healthcare provider into a credible sexual health provider. It's not impossible. They just need to spend some hours learning.
Yes, but there is a question, because it seems like on one side, we have people with cancer who are afraid. I mean, the professional, the cancerologists, they are afraid of sex, and the sexologists, they are afraid of cancer. And
yes,
and there is a new discipline which is called oncosexology, which tries to integrate, I would not say these fears, but to overcome these fears. So is it possible to have someone who would have the two capacities to deal both with cancer and with sexual problems and difficulties?
Yes, absolutely. Like with Janothan, as you said, is now for us like the father of oncosexology. I've learned a lot from him about oncosexology.
Eric?
On this specific topic, I do not have anything to add, but can I jump in? I saw in the chat a
yes,
point
please.
Go ahead.
About
the term sexually active is not universally understood among lay people. How about, do you have sex of any kind with another person? I think that is such an excellent point, and especially to healthcare providers, clinicians, and medical doctors. There are some beautiful studies in the literature on what actually that word means to people. One of the first study in this area was actually published in JAMA, Journal of American Medical Association, by some of my Kinsey colleagues, Stephanie Sanders as first author, in which they asked subjects, would you say you had sex if ... And the main conclusion of that study, which has been replicated in different countries, different populations, is that if people have very different ideas about what encompasses sex or having had sex. So this is a very good point. And I think actually one of the main conclusions of that paper is that clinicians, doctors, therapists should be very specific. And so asking, do you have sexual experience is not a very good question. Do you ask, have you had sex of any kind is not bad, I would think. But better is to be specific. If you are interested in terms of, for example, pain problems or etc., about sexual intercourse, then ask about that. Then don't say, have you had sex or so. But also when you work with young people, it's very important to be specific. A lot of young people would, for example, not consider anal sex because you cannot get pregnant from it. It's amazing. The numbers are kind of disturbing. So it's important to be clear on terminology. I just want to add, I think that's a very good point.
Yes, and thanks, Eric. And it's so interesting because if you actually go and look at the process of care of SWITCH, if I remember correctly, it actually says, are you sexually active with yourself or other people? I think that's the word. But for me, as a clinician in South Africa, where 82% of our population are church going, and those who don't go to church, go to mosque or to the synagogue. So, we have a very religious society. I cannot ask, are you sexually active with yourself or other people? I cannot ask that in my context. It's impossible. I will offend that person immediately and lose them. Of course, there are some people that I could ask that question to like that, but as a basic assumption, I have to be culturally appropriate, and asking, are you sexually active, is like, it's a little bit of a euphemism that everybody in my culture is kind of familiar with. But of course, you're going to miss a lot of things. But it's a very good point to show that everything when it comes to sexuality has to be that whole sentence about scientific evidence and rights-based, and then experience informed and culturally or context sensitive.
I think it's an excellent point. I just want to add to that it depends indeed what the purpose is, what you're trying, if it's in a context of STDs or and someone says, no, I'm not sexually active, because they have certain types of ideas about what that means, and oral sex is not part of that. So that's mainly, but I think, yeah, I understand the complexities of asking Michael.
Yes, there was a question from someone who is asking how can we improve pleasure in people with STIs, especially people with genital warts. They have some limitation in touching and sensate focus and some for increasing pleasure. So what can you do if you cannot touch, the genitals? Which means that, is pleasure located exclusively in the genitals or not? And
I think you partly answered the question by pointing at the fact that there are so many different ways to experience it. But having genital warts or other conditions may more generally impact indeed how you feel about yourself, your sexuality, your body. So yes, but as in many cases, people may have lots of factors that may impact their body image, their what they can do physically. So it's part of a larger question indeed of what are the requirements to experience sexual pleasure, and the strict focus on genital stimulation and genital sensations. It's probably somewhat limiting in general, and pleasure is in the brain.
Thanks, Eric and Alan. I think Dr. Brock had to leave because he was literally running in and out of surgery. So I think that leaves it to me to close tonight's webinar and to thank you, Alan, for your moderation. Eric, thank you for your contributions. It's wonderful for me to be on a webinar with the two of you, and Patricia Pascal, who was on the WAS advisory in the last administration as well. We know her well. And thank you to ISSM for hosting us tonight, as WAS, and doing this jointly. As you could see from the chat, we had fantastic feedback, and this will be available on demand, so you can come back to it, you can refer your friends to it. I hope that you picked up many practical skills to bring pleasure to your patients in an ethical manner. Thank you to ISSM, and thank you to everybody who joined.
Thank you. Good evening.
Thank you.
Good night.